next we have a gene therapy update from Dr. Christy Duncan at Boston Children's Hospital.
I can just supply an answer to one of those questions from our center. So I know at Boston Children's, we've treated 4 patients with a commercially approved product, collected another patient, are in process, and working with some other families right now. I don't know the numbers about the other sites. So you've heard a lot of updates about gene therapy so far and about conditioning. I promise, interest of time, I'll skip over things that are redundant. So what I've been thinking about is, we know where we are, but where are we going and what's next? So starting with where we are, Vinod had a great slide that was like this, that I'm just including a couple more things here, and those are the boys who are diagnosed with MDS and with AML. Because I think, just for me always, it's a reminder that this time course has been one of, or timeline, somewhat like ALD, of some really wonderful moments of joy, alternating with gut-wrenching decisions and gut-wrenching pain for families, for providers, for all of us. And so I think where we're thinking about where we're going, it really comes a lot, or is very much related to how we think about the myelodysplasia. So where are we going? My father was a Star Trek fan, and so we'd always talk about boldly going where no one has gone before. But I think we also need to boldly yet safely go there if we can. And as I've said, much of this comes down to myelodysplasia and leukemia. Before we had those first cases in 2021, things looked great. If you had asked me, should people have a transplant or gene therapy? Gene therapy is fantastic. And then we've had those cases which are so important that have made us pause and think as we should. And so anytime someone has a cancer diagnosis, and as we've heard from the 2 prior speakers, MDS is cancer, AML, which is leukemia, is cancer. After cellular therapy, such as gene therapy or transplant, we ask ourselves a couple of questions. In the gene therapy world, is it the product? Is it something related to this gene therapy product that is increasing that risk of cancer? We ask ourselves about the chemotherapy, not in the ways that we've been talking about it today, whether busulfan and fludarabine versus busulfan or Cy gave some advantage, but you can get cancer from chemotherapy. Often it happens years later, but it's happened in other gene therapy trials not related to the product. So we have to ask ourselves, is that the problem? And then we wonder, is there some risk of the underlying disease? Is there a reason that boys with ALD have AML or MDS after treatment more than other populations? And I can say quite definitively we don't have any evidence of that right now. And so really coming down to those thoughts, we think about those top things. Is it chemotherapy or is it the oncogenesis? And I'll talk about what that means. And the answer in these cases, it really does appear to be related to the product and to something called insertional oncogenesis. It says savvy room, savvy audience on Zoom. But just to review, because I think it helps set us up. So you know the process for doing the gene addition. The patient gets GCSF, a drug under their skin for 4 or 5 days. They get connected to a machine. The blood cells are collected. And then what happens is that those blood stem cells are sent to a laboratory, where in that lab, a vector, so the delivery vector, which is derived from HIV, it cannot give you HIV, it has genetic modifications in of itself, but that vector, or sort of the pickup truck that's going to carry it in, is paired with the gene. We call it the transgene. That's the one you want to give the person. And so in this case, the ALD, the ABCD1 gene, is what we want. That vector carrying the product and the patient's own stem cells are combined in a lab, and now you have the patient's stem cells that is mixed with and has in their DNA, in their genetic material, the healthy gene. And why do we use blood stem cells? Other than the reasons that Tim told us for why we think stem cells can help in this disease, we use them in gene therapy because as they divide, that healthy gene gets passed down from generation to generation to generation of cells, of the blood-forming stem cells. We don't want to cure ALD or stop ALD for 2 years, for 2 months. We want to stop it for a lifetime. So we need cells that are going to divide and continue to pass on an ALD, ABCD1 gene. One of the foundational things I think is important to understand about gene therapy and the risk for cancers is that we know, whoops, I think we have an old version, shoot. We have an old version of my slide, so we're just going to roll with this right now. So we have, this is a sickle cell gene, which is there, not intended to be. So we look at our old cells and we think about sort of where the vectors land, where it happens. So we want to replace, when we put the genes in, it doesn't go necessarily to the X chromosome. It doesn't go to the spot. It goes anywhere. This is semi-random insertion. So you can put that gene anywhere in the entire genome. And if it goes next to a spot that's causing problems, that increases your risk of cancer. And so that's really fundamental to our understanding. And so just going back to where we were and thinking about how gene therapy works in delivering that gene. So just reminding, stem cells from the patient mixed with a vector, an HIV-derived vector carrying that healthy gene, are mixed together, and those cells, that healthy gene is then part of the patient's DNA where it lives after generation and generation. And that's what we want. So as those host cells divide and carry the gene forward, that ABCD1 gene present in that first cell is still there in all of the ones that are coming after it. Here we go, correct chromosome. So the purpose, as we said, is to put this in the patient's genome somewhere in their DNA. And to some degree, it doesn't matter where it lands, but to other parts of this is actually really important. So that healthy ALD gene could land in chromosome X, could also land in 1, could 2, any of the genes that that patient has. And so this integration site, this is going to come up. So that spot where it lands, where it integrates or inserts itself into the DNA, that's something that we watch. And families who have children on the gene therapy studies or commercial know that we talk about the integration site a lot. And you can have thousands of different integration sites. And for this particular product, that's what we want. And that's where the ALD protein is coming from. So in essence, we are making mutations. So there's this concept of insertional mutagenesis. And this means the new gene is being inserted somewhere, and it's causing a mutation in a gene that happens to already be there. And most of the time, that's fine. Most of the time, it doesn't cause a problem with anything around. So we know, though, that those inserted genes can impact the actions of the genes around them. So sometimes it could take that gene that it happens to have landed next to and change what that gene does. Sometimes it could turn it off. So you've got a gene that was doing something before, and now it's not because of its new neighbor. It can change the amount of the proteins made, so you can make a lot more, a lot less, and then most of the time, it doesn't do anything. Most of the time, we find it lands in that neighborhood, and nothing really changes besides the action that we want. Insertional oncogenesis, on the other hand, this is the phenomenon where that gene is still inserted, it's still integrated somewhere, but it causes a cellular transformation by altering the expression of a neighbor, someone who lives nearby, a neighborhood gene, that increases the risk of cancer. So we think of these things called oncogenes in the body, that when you turn them on, they increase your risk of getting cancer. It alters how your cell cycle is controlled. So if that gene lands next to an oncogene and happens to turn it on, you are at increased risk for cancer. If it also lands next to a gene well named a tumor suppressor gene and turns off that gene's job is to have proteins that decrease your risk of cancer. So if we turn that off, then that increases your risk as the same way, different genes. So how does this happen? How does this happen in the products that we're talking about? So in this example, that yellow happens to be the integration site for the gene, and these are the cells. And this one is the one that we don't want. It's got that gene in the spot we don't want it. Over time, it divides. Some of the cells, as it divides, have that clone, and some of them don't. But over time, that clone can expand. Cells that are pre-cancerous or pre-malignant have a survival advantage. That's why cancer is a problem. And at the end of the day, it can lead to this development of MDS or transformation into leukemia. So that's what we see now. So all those cells dividing and dividing have this malignant population or this malignant potential. Not every single cell in the body, but they're there. And so this is what we think is happening with the patients we've been talking about. I remember at this meeting, last year we were talking about sort of the difference between MDS and AML, or MDS and leukemia, and that has really tragically come into focus in the past month. So before we were talking about 5 boys who developed myelodysplasia, and now, as we've heard from Vinod, there's a child who has AML. And so I just want to talk about those differences so we can all understand what we're talking about. They're part of a spectrum. So we think about MDS versus AML. In MDS, typically you have decreased production of the healthy blood cells, so the red blood cells, the platelets for your clotting, or your immune cells. There's abnormal development. If we look in the marrow, we can see cells that, sort of trust me on this, look a little wonky in the marrow, things that we don't expect. typically it is a less fulminant, less aggressive course in the moment. So oftentimes there is time to plan, time to think about what we are going to do for a patient. AML is different. So not just in the marrow or in some degree of the circulating cells, there's a significant decrease in those healthy blood cells that are there. You have presence of immature cells or cancer cells that are circulating throughout the blood and in the marrow, and it is aggressive. It is a clinical course that requires immediate action. So just to summarize this, both of these things are cancer. They both negatively impact the normal development of healthy blood cells. There are multiple different types. So if you may have had a friend, a family member, someone who's had MDS, someone who has AML, they're probably not necessarily the same kind as we think about in children. So different types of AML, different types of MDS. And so they are all part of this same spectrum. This slide, I think, is just to help understand why sometimes we use the language doesn't seem as precise as we would want it to be when we talk about whether a child has MDS or has AML or has something in between. So if we start over here at the normal, so this is normal marrow, and we talk about blasts in oncology, we're talking about the cancer cells. So less than 5% of these cancer cells circulating. As you go into MDS, you're having blasts develop, some of them in the marrow perhaps, but it's not as many as AML. MDS, your bone marrow may not be producing enough cells. For some of the boys that we've treated, if you've seen the MDS at our center and others, the platelet count goes down. So we're watching that platelet count. So you're maybe not making quite enough because of it. But as time goes, you get more blasts in the marrow, and you see overgrowth of these cells, and then you're at that leukemia point. The standard of care for pediatric patients with MDS and AML is an allogeneic stem cell transplant. And that's for MDS because it's going to progress, or is almost more likely than not to progress to AML. So we want to intervene before that so that patients don't need chemotherapy if we can help it before they go to the MDS transplant, and because the outcomes are much better for patients who have MDS than AML. And so I think, on those slides that Vinod showed us, there were some boys who had MDS but got chemotherapy before they came into transplant, but they weren't called leukemia, probably because they were living in this area. So not quite AML, not quite MDS, but people wanting to decrease that burden that they were carrying. So being more specific about this product and about Skysona or Elicel in the studies, I should say, how did it lead to MDS? Or how do we think that it's leading to MDS? It all comes down to, or most cases, 5 of the cases that we know of, or 4 of the cases that we know of, I think we're still learning about the 5th, it comes down to this thing called the MECOM. This happens to be a gene, one of those oncogenes. You turn that on or rev up that treatment, you're going to get the increased risk of cancer. What this really complicated, sort of mushed together diagram is showing us is how many patients who are treated with Elicel or the Skysona, the gene therapy product, have integrations or insertions in the MECOM. And this looks like a lot. And that is a lot. Every patient on this study has had an integration there. Most patients it has not turned into, and is not expected to turn into anything. And this is not just true of gene therapy for ALD. This is true for gene therapy across diseases. This is a spot where genes are often inserted, and we're trying to understand why some patients go down the road of MDS, AML, and others don't. So what this says to me is that we need the different vectors. We need to think about this differently. How can we move forward? That takes a very long time, and not all of the boys who have ALD, most boys who have cerebral ALD don't have that kind of time. We think about the future in gene editing, which is where you're giving more specifics. So you're putting the gene or trying to put that new gene in a real specific spot. So we think about that. And perhaps if this is related to the chemotherapy, which we're still trying to understand, we need to do different chemotherapy. Or Dr. Olson was talking about the non-chemotherapy-based conditioning. We're not there yet for any of those things, but people are thinking about them and working on them. So what are we doing now? So this is a complicated slide that shows you how we're following the boys currently who are treated on the studies. So blood counts, a CBC, every 4 months for 10 years. We're also doing the integration site analysis, telling us where those genes were inserted at those same time points. If there's a blood count abnormality, we repeat it. And right now I'm just speaking to families who have children who have treated on the study or those going forward, platelets are finicky. They are divas of the CBC. If you are sick, if you're not, they go up, they go down. If your child is asked to have a repeat CBC, it does not mean that they have MDS. It's entirely possible that they had a cold, that there was something in daycare, but none of us are taking chances. So get the CBC, let's repeat it. Most of the time, it's going to be fine. We're doing bone marrow biopsies now. We're going to the source. So bone marrow biopsy involves putting a needle into the hip bone when your child is asleep and looking at the marrow and trying to see if we can find things early so that we can try to prevent the progression to leukemia. And now, as we also heard about, there's a long-term follow-up registry for commercial products. So the graph that I have up here, this is the graph for people on the study. The follow-up for boys who are treated commercially is different and actually more intense, and this is because of parameters that were put in by the FDA and also just good medicine and good care. This is not an ALD patient's integration site analysis, but this is a map that families in this room, on Zoom, other sides who have seen this in clinic, this is a representation of how we look for that spot, how we look to see if things are changing. So in this case, each of these colors and all of the letters and names listed here, these represent a spot in a gene. When we get a map, it tells us the top 10 spots that gene happens to be inserted. Patients often have thousands of these spots. And so what we do for each of them is we look at the name of the genes and we're like, are any of these problematic? Do we need to watch this particular one? So we look at that not just once, but over time. We also look to see how much of the population that gene is representing. And so if you've got a huge portion of it, it makes us wonder, are those cells dividing faster than the others? Are those cells increasing that risk of cancer? So we look at that over time. And so that's something we think as it is, that's called dominance. And in this particular case, for a patient, different disease, different study, we can see there's a lot of changes over time. And this is a map that maybe you would have concerns or maybe you wouldn't. But I think also last year at this meeting, we talked about this 5%. And are we doing marrows? Are we thinking about that? The current standard for our patients who we've treated with ALD gene therapy is if you have any one of these spots that happens to be a gene related to cancer present more than twice, and it's 5%, we're going to do a bone marrow, or we're going to ask you to do a bone marrow, and we're going to talk with you about that. And so that is a standard across all of our sites. So what are we telling our patients? How are we counseling people? I mean, every provider who sees patients is going to do this a little bit differently. But I think the themes before therapy, we'll take a history. If there's anything that's worrisome, if there are any counts that are off before, we'll consider even doing a bone marrow before, just so we're looking at that. And we talk about it. I don't want any patient of mine, of yours, anyone in this room to come in and never have heard about this risk before. This is part of the importance of the counseling and the consent. After treatment, we do the integration site monitoring. We look at that map. We look at the colors over time. We do routine CBCs. And for families who are understandably and appropriately anxious, there's nothing wrong with getting CBCs more often than we're recommending getting a CBC, so we can follow them more frequently. And looking for symptoms. We have seen over time that the CBCs have more predictive ability for patients who develop MDS or AML than the integration site maps. So watching CBCs, which thankfully is a whole lot easier than getting these integration site maps, is something we can all do. And then in the future state, and now moving in there, international registries, translational research banks, and then trying to share this data, and perhaps at some point as we understand more, we can try to give you a risk stratification to think about who's at higher risk or lower risk because of any number of factors for malignancy. So moving on from that, that is clearly a driving factor and perhaps for many of us the most important factor we think about. But then there are questions that came up during other presentations about other challenges. So what's different now that we have commercially available SKYSONA compared to when you're on studies? There are lots of things that are difficult, some things that are fantastic that this is available, others that are tricky. So patient access and cost. I think that you've heard that the therapy is available currently at 4 sites in the United States. If you don't live near one of those sites and your child needs gene therapy, then you are going to, I guess, pick your climate, whether you're going to Boston, Philadelphia, Stanford, or California or Minnesota. All of us are happy to take care of any patient, and you'll get good care at every single one of those spots. But that's not easy for everyone. Not everyone can pick up your whole family and move some of your family, do those things, travel, and so people try to help you. There was a question, I think, before about the cost and how are insurance companies covering this. It takes a lot of work from families and from the treating sites, but the insurance companies are covering it. We've never had a patient denied. It usually requires a lot of conversation. It requires hospitals actually have individual case agreements made, but the hospitals are committed to that. That's part of why you are a qualified treatment center. You are dedicating the effort to making sure people get covered. There's also been a lot of proactive work, both from Bluebird and treating sites, to educate the insurance companies to why this is so important, why we need this available for patients, and why we need it quickly. One of our first patients we treated at our center, it took us 3 months to get approval, and that patient happened to have a less score of 1 and an F of 0, so that was okay or acceptable, I guess, at the time. But then recently we had another patient who happened to be on our state-based insurance, who we had approval in 72 hours. So I think insurance companies are catching up and understanding. So I think that access a year from now, 2 years from now, is going to be a whole lot different than it is right now. One of the other things that I think is quite challenging, it gets to a question that was asked also about the less score of 9 and other things, is related to insurance. As a provider, I might want to treat someone with a less score of 10 because I think that there is going to be a good outcome. The insurance companies, at least this far, have not strayed at all from the label, like are unwilling to even move, things that maybe even seem small about a certain lab or something. So I would hope that changes in the future, but right now, realistically, even if the providers and the families want to do that, I think our hands are likely tied because of that. The other piece about patients who have higher scores is that because of regulations that the FDA put in after the trial, the testing that is done on each product afterwards takes at least twice as long. So on the clinical trial, we could reliably get cells back in 4 or 5 weeks. So you could collect your cells and we would tell you your next admission date for the transplant. Because of the creation of the product is no different, the testing now takes 2 or 3 months. And so if you need to have insurance approval, get the product, have your collection, and get the product, you could be looking at a 6-month window, hopefully shorter. I know Bluebird's working on trying to get shorter. I know Dr. Olson, myself, others are trying to talk to the FDA about some of these things. We want a safe product, but we want a product in time. That's probably not okay for people who have a higher score. Not probably, that's not okay for a patient who has a higher score. The conditioning, as we heard from Dr. Olson, is not the same necessarily. It doesn't have to be the same across every site. I know lots of us are trying to do the same thing so that over time we can understand safety and efficacy better. But when we think about things that are now commercially available, there is long-term follow-up, but we have to try and figure out how we're going to understand if it's working still. And that is part of the Bluebird study that's being done, the registration trial. But it's really different than a study when everyone gets something at the same point. We know when they're getting their MRIs. We know when they're getting, whatever testing is being done. That's different in a commercial setting. And then understanding the safety and the long-term requirements and how we're supporting families. I think just one last thing that I didn't say about this that is meaningful to me, and I don't know how we address this as a community. There were many patients internationally who participated in the clinical trials. I think close to half, if not more than half, patients came from outside the United States. You can't do that in a commercial setting because patients can't afford the cost of it. Very few governments, there are some governments in the world that will support families coming. We have families from Israel and from Italy where because they have no other donor options in the world, their governments may pay for them to come here. But it is a gut punch to all of us that there are relatives of people who are on this trial who can't get the therapy because they are not United States citizens or live in other countries. So I think that is something as communities of people and children with rare diseases, we need to think about how we can spread therapy other places. That's hard for all of us. I know everyone gets calls all the time from around the world. So it sounds like I've said a lot of negative things. I still think that this is an important therapy. I still think that families who have children who do not have donors in the registry need an option. I think we talk about how everyone has a half match, a parent or a sibling. Not everyone has a half match. Lots of people don't. We need to have ways to get therapy. And I am not going to say that gene therapy is right for everyone. If you happen to have a matched sibling, I actually think that that's probably the better route. If you have no donor, gene therapy seems like a great route. In between is hard. And I think we have to figure that out as a community, but individuals and families and their providers need to have that conversation, and it needs to be in depth and understanding so we can move forward together. So obviously the most important acknowledgments to any of this are you, patients and families and the community. Thank you for putting your trust in all of us. Thank you for sharing your families with us. I also obviously want to acknowledge Bluebird and then my partners at Massachusetts General Hospital and Boston Children's Hospital who have been, family to all of us, so thank you. I know we are tight on time. If there are time for questions, I'm happy to take them. There are questions, okay. Let's do that.
Hi, thank you so much for all those great talks. Susan from Bluebird Bio, who is here on Zoom, has an answer to the question that Dr. Waldman asked regarding how many patients have been treated since the FDA approval. So I just want to read, 6 patients have been treated after FDA approval with Skysona based on the latest public information from Bluebird Bio. And also her slides that she was originally planning to present today are out on the table just outside the atrium. Thank you, Susan.
Thank you for the wonderful presentation. I was a bit curious to know that are we looking for any targeted gene editing strategies like CRISPR-Cas9 or anything for this? Because you told that since you are not aware of the integration where it is integrating and it is leading to the tumor affecting the tumor suppressor gene, which lead to malignancy. So are we looking for any study where we are actually working for alternate gene editing strategies?
So, there are challenges with gene editing. It basically is where you have an enzyme that sort of targets a real specific spot in the gene to get rid of it, to change it, to do something else. That I think is ideal for many situations. It works best when there aren't multiple different types of mutations because you'd have to have a different strategy for each of those. But there are some gene editing platforms that can replace whole genes or insert them differently. So there are no open trials right now. I know that there are a few companies and academic centers that are looking at that. So I think that's one way to move forward for sure. Thank you. Thank you. Let's have lunch.